All right, in this explainer, we're going to build a practical guide to a condition you see every single day in the pharmacy, irritable bowel syndrome. We're going to cover everything from diagnosis all the way to your most critical counseling points. So, why are we focusing on IBS? Well, get this. An estimated 12% of people in North America have it. So, what does that mean for you? It means a ton of your patients are walking through your doors dealing with these symptoms, whether they've been officially diagnosed or not. So, what exactly is IBS? It's not just a simple stomach issue. It's actually a disorder of the gut-brain interaction. And that's a really key concept because there are no lab tests or biomarkers for it. The diagnosis is made entirely based on symptoms. Okay, so here's our game plan. We'll start with diagnosis and some really important alarm signs. Then we'll jump into lifestyle and diet counseling, talk medications broken down by IBS subtype, cover the special case of pregnancy and breastfeeding, and wrap it all up with your very own counseling action plan. All right, let's dive into our first section, diagnosis and alarm signs. This is where you, as a pharmacist, are absolutely critical. It's all about understanding the framework for diagnosis and, just as importantly, knowing when to say, whoa, this needs a referral to a doctor. So the official diagnosis is based on what's called the Rome 4 criteria. The key thing to recognize is this specific pattern, recurring valley pain that's clearly linked to changes in their bowel movements. Now, your job isn't to diagnose, but it is to recognize when a patient's story fits this pattern. Okay, so how do we get from that general diagnosis to a real practical treatment plan? It all starts with one super simple tool, the Bristol Stool Form Scale. Using this is absolutely the crucial first step to figuring out a patient's IBS subtype, which then guides everything you recommend next. And this chart here, it lays it out perfectly. Based on whether a patient's stool is usually hard and lumpy, or loose and watery, or maybe a mix of both, you can figure out if they have IBS with constipation, IBS with diarrhea, or the mixed type. It's a simple classification, but it dictates your entire approach. But hold on. Before you even think about recommending a single product or offering any advice, you have to pause and ask the most important question of all. Could this be something more serious than IBS? And this is non-negotiable. Your absolute first responsibility is to screen for these alarm signs. If a patient mentions that their symptoms started after age 50, if they see blood in their stool, if they have diarrhea that wakes them up at night, or any of these other red flags, your recommendation is simple. Stop and refer to a physician immediately. Okay, so once you've ruled out any of those red flags, management really begins with the non-drug advice. Let's move to Section 2, counseling on lifestyle and diet. This is the foundation of managing IBS, and it's a core role for every single pharmacist. First-line advice often starts with fiber, but, and this is a big but, not all fiber is created equal, especially for a sensitive gut. You want to recommend soluble fiber, like psyllium. It actually helps with overall symptoms. On the flip side, insoluble fiber, like wheat bran, can make things worse. We're talking more bloating and more pain. It's a simple but vital distinction to make. Now here's a key counseling pearl that will make a huge difference for your patients. Don't just tell them to take fiber. Tell them how. The magic phrase is start low and go slow. Starting with a small dose and increasing it over several weeks helps minimize that gas and bloating that makes so many people quit before it has a chance to work. All right, what else is in our lifestyle toolbox? Well, you should also talk about these points. A low FODMAP diet trial can be really effective, but you have to emphasize that it should be done with guidance from a dietitian. Also, don't forget the proven benefits of physical activity and the potential role for probiotics. So what happens when those lifestyle changes just aren't cutting it? That's when we turn to medications. And the choice of medication is guided almost entirely by the patient's IBS subtype. Okay, let's talk IBS-C. Think of it like a step-by-step approach. You start with fiber. Then you can add an osmotic laxative, like PEG, if needed. For more complex symptoms, there are agents like linaclotide. And here's a huge counseling point for that one. It has to be taken on an empty stomach, 30 minutes before their first meal of the day. Now for IBS-D. And you might be surprised, but psyllium is still useful here as a bulking agent. For loperamide, you want to counsel patients to use it as needed, on demand, not continuously. And for other options like aleuxodiline, you have to screen for the big contraindication. It's a definite no for any patient who has had their gallbladder removed. I love this slide because it's a perfect example of where a pharmacist adds incredible value. This one small piece of counseling for an antispasmodic like penevirum can prevent some really nasty esophageal irritation. This is Pharmacist value in action, right here. So what about when pain is the biggest complaint? That's when we start thinking about neuromodulators. The key here is to match the drug's side effect to the patient's symptoms. TCAs tend to be constipating, which makes them better for IBS-D. SSRIs can get things moving, so they're a better fit for IBS-C. And it's critical to remember that TCAs are used at much, much lower doses for IBS than for depression. Okay, this is a big one. You're definitely going to get this question. What can I take for my IBS now that I'm pregnant or breastfeeding? This is where the approach shifts to prioritize safety above all else. The mantra here is simple: non-drug therapies first, always. If a medication is absolutely necessary, bulk-forming agents like psyllium are your safest bet. The crucial point on this slide is avoidance. We avoid drugs like linaclotide not because we know they're harmful, but because we just don't have enough human safety data. So we stay away. Okay, we've covered a lot. So how do we pull all of this together into a simple, repeatable action plan you can use during your next patient interaction? Here it is, your 5-step action plan. Step 1, identify the subtype. Step 2, screen for those alarm signs. Step 3, counsel on lifestyle first. Step 4, select drugs that target the main symptom. And finally, Step 5, build the relationship. Remember, IBS is chronic. Your empathy and ability to set realistic goals are invaluable. So at the end of the day, using a structured, evidence-based approach like this means you can do so much more than just hand over a medication. You can help relieve chronic symptoms, provide that crucial education, and truly, truly improve your patient's quality of life. The only question left is, how are you going to use this to help your next patient with IBS?